Today we are going to discuss about an important gynecological topic while discussing some questions. So let's get right at it. Mrs. X was admitted to the gynecological emergency with a moderate abdominal pain. She is known to be around 6 weeks pregnant. She gives a 2-day history of vaginal bleeding of dark colored blood and presented with a newly onset shoulder tip pain and dizziness. Her blood pressure 100/50, pulse 100, and temperature 36.9. An ultrasound scan reveals an adnexal mass on the right and some free fluid in the pelvis. There was no gestational sac in the uterus, and beta HCG sent by her GP a day ago was 4,000 international units. So what is the diagnosis? This is an ectopic pregnancy. An ectopic pregnancy is defined as an implantation of conceptus outside the normal uterine cavity. The common sites of implantation are the fallopian tubes, ovaries, and the peritoneal cavity. In the fallopian tube, the distribution of sites of implantation are the ampulla, which is the most common site, isthmus, fimbrial end of the tube, and the interstitium. There are many etiological factors contributing to the risk of ectopic pregnancy, like tubal disease, pelvic infection, previous ectopic pregnancy, previous tubal surgeries, subfertility, and the use of intrauterine devices. So how do these patients present? The majority of patients present with a subacute abdominal pain and vaginal bleeding in early pregnancy. This vaginal bleeding is usually dark red, and the abdominal pain may be localized to the iliac fossa, and they can also present with a shoulder tip pain which is indicative of free blood in the abdominal cavity causing diaphragmatic irritation. They can also have symptoms of dizziness due to anemia. When you do bimanual examination, there will be tenderness in the fornices, cervical excitation, and if the ectopic pregnancy is ruptured, they can develop hypovolemic shock and acute abdomen signs. So now let's talk about how to investigate an ectopic pregnancy. The diagnosis of ectopic pregnancy is usually suspected by the presence of period of amenorrhea, abdominal pain, and bleeding. An ectopic pregnancy should be suspected in a woman of a childbearing age who complains of the abdominal pain even in the absence of a period of amenorrhea. The next step in diagnosis is to perform a transvaginal ultrasound scan. If an ectopic pregnancy or an intrauterine pregnancy is not identified by the scan, we can perform a serum beta HCG levels and repeat the test and the transvaginal scan in another 48 hours. If the level shows a rise less than 63% and there is no intrauterine pregnancy, an ectopic pregnancy or a pregnancy in an unknown location is suspected. In here, laparoscopy should be performed in these cases to confirm the diagnosis and for its management. If the serum beta HCG level rises by more than 63% or it doubles, a developing intrauterine pregnancy is confirmed by performing a transvaginal ultrasound scan within 3 to 7 days. And if the level falls by more than 50%, a diagnosis of a non-viable pregnancy is made. When we are doing the transvaginal ultrasound scan, the following ultrasound features are used to diagnose an ectopic pregnancy: an absence of an intrauterine pregnancy, positive identification of an inhomogeneous mass, empty adnexal gestational sac, or an adnexal sac containing a yolk sac or a fetal pole. Presence of free fluid in the peritoneal cavity is also suggestive of an ectopic pregnancy in the absence of intrauterine pregnancy. So now let's move on to our next question. A 20-year-old woman complains of a sudden onset right-sided lower abdominal pain and bleeding per vagina. Her last normal menstrual period was 35 days ago. Her blood pressure is 90/70 and pulse rate is 100. There's tenderness and guarding in the right iliac fossa. She denies any sexual intercourse. What is the most appropriate next step in the management? Answer A is estimate serum beta HCG levels. B is obtain a surgical opinion to exclude acute appendicitis. C is to perform a laparoscopic examination. Answer D is perform a transvaginal ultrasound scan. As her hemodynamic condition is fairly stable, the next step in the management is to perform a transvaginal ultrasound scan. And this is to confirm the diagnosis by absence of intrauterine pregnancy and the presence of free fluid in the peritoneal cavity. The estimation of serum beta-HCG levels has a little value, especially when there's a ruptured ectopic pregnancy suspected, because the diagnosis can be confirmed only after repeating the test in 48 hours. So now let's talk about the management of ectopic pregnancy. The ectopic pregnancies can be managed by using expectant, medical or surgical approach, and this depends on the clinical presentation and the patient's choice. In expectant management, this option is suitable for patients who are hemodynamically stable and asymptomatic. This entails the serum beta-HCG measurements and ultrasonography. In here, we'll wait and see if it resolves on its own through regression or a tubal abortion without any treatment. In medical management, systematic methotrexate is the treatment option, and methotrexate is a folic acid antagonist which inhibits DNA synthesis in trophoblastic cells. So what are the indications to the use of methotrexate? Cornual pregnancy, persistent trophoblastic disease, patient with one fallopian tube and fertility is desired, patient who refuses surgery or in whom risk of surgery is too high, treatment of ectopic pregnancy where trophoblast is adherent to bowel or blood vessels. There are few contraindications to this medical treatment, that is chronic liver, renal or hematological disorders, active infection, immunodeficiency and breastfeeding. And while the patient is on methotrexate, we should make sure that they know about the side effects like nausea, vomiting, stomatitis, conjunctivitis, gastrointestinal upset, photosensitive skin reactions, and about 2/3 of the patients will suffer non-specific abdominal pain. We should also advise the woman to avoid sexual intercourse during the treatment and also to take some form of contraception for 3 months after the methotrexate treatment. We should also tell them to avoid alcohol and exposure to sunlight during the treatment. Next, we have surgical management. The surgical treatment can be done by laparoscopically or by laparotomy. Laparoscopic surgery is the mainstay of management. Laparotomy is mainly reserved for severely compromised patients or due to the lack of endoscopic facilities. During the surgery, the fallopian tube can either be removed, that is known as salpingectomy, or a small opening can be made at the site of the ectopic pregnancy and the trophoblastic tissue can be extracted via the opening, that is called salpingotomy. In general, if the patient has a normal remaining tube, salpingectomy is the treatment of choice. Salpingotomy is thought to be associated with a higher rate of subsequent ectopic pregnancies. So now let's move on to our last question. A third para is admitted with a history of sudden onset right-sided lower abdominal pain and bleeding per vagina after a period of amenorrhea of 5 weeks. Her blood pressure is 90/70 and the pulse rate is 110. Transvaginal scan reveals the presence of a large amount of free fluid in the pelvis and the absence of an intrauterine pregnancy. What is the most appropriate management? Answer A is perform laparoscopic salpingectomy. Answer B, perform laparoscopic salpingo-oophorectomy. Answer C, perform laparoscopic salpingotomy. Answer D, perform a salpingectomy through a laparotomy. A diagnosis of ruptured ectopic pregnancy can be suspected by this clinical picture. So the diagnosis is confirmed by demonstrating free fluid and the absence of intrauterine pregnancy on the transvaginal scan. The most appropriate management of a ruptured ectopic pregnancy is laparoscopic salpingectomy. That is the answer A. Salpingotomy is done only in women with contralateral tubal damage, and there's no place of medical management with methotrexate when they have a ruptured ectopic pregnancy. So the answer is answer A. So if you have any questions, you can drop them as comments below. I'd love to hear your suggestions on how I can improve my content. I'll see you guys all next week with another interesting video just like this. Until then, take care and goodbye.